Welcome again, everyone, to another in our series of interviews with the experts. I'm Malcolm Bell, your studio host for this. And I'm really pleased to welcome Dr. Maan Jokhadar, who's a colleague in the Division of Structural Heart Disease here within our department. He's an expert working in the area of adult congenital heart disease, an associate professor of medicine. He's also the current medical director of our cardiac intensive care unit. So welcome, Maan.
Thank you, Dr. Bell, for the kind introduction.
Yeah, so we're here to talk about adult congenital heart disease, and this is going to be the first in a three-part series focused on the management of adults with congenital heart disease. And I think it's fair to sort of kick this off by just reminding everyone that there's been a dramatic improvement in the survival of patients with congenital heart disease, and even the most complex congenital heart disease, living into adulthood. And certainly the impression that so many people have, even outside of your specialty, is that the prevalence of this in our adult patient population is as high as it's ever been. So maybe you could just start talking to that in terms of how common this is and why we should be interested in this as practicing cardiologists or other providers for our cardiology patients.
We are all going to be taking care of these patients. No matter what specialty, no matter what field of medicine, we will at least be peripherally involved in their care. The 1 to 2% of us are born with a heart condition. And because of improving medical care, improving surgical care, the majority of these patients are making it to adulthood. And now there are more adults with congenital heart disease than there are children, and that population continues to grow. So no matter what field, no matter what specialty, we'll be taking care of these patients. The other important point is, these patients are rarely cured. The surgeries have improved, medical therapies improved, but the majority of these patients will require at least some interval follow-up and care. And some of these patients with a supposed complete repair will still have some significant residual problems. So we all need to have some familiarity and be able to reach for the available resources in our communities.
In this podcast, we're really going to start we're going to focus on the hospitalized patient with adult congenital heart disease. And this is obviously where the more serious conditions are going to be found. Maybe you could just start telling us why are these patients admitted to hospital? And I assume that sometimes it's cardiac, and it's clear it's a problem with their underlying condition. Many of them have had procedures, surgeries, and others it may be totally unrelated to a specific cardiac problem. So maybe just walk us through that, and maybe focus on the cardiac presentations first, and then we can talk about the non-cardiac.
Depending on the condition, there's an increased risk for certain cardiac manifestations. Certain heart conditions, certain congenital conditions can increase the risk of heart failure, ventricular dysfunction, ventricular arrhythmia, cardioembolic events, strokes, and even coronary disease. And so depending on the underlying condition, for example, someone with congenitally corrected transposition, for example, maybe at increased risk of both heart failure and heart block. Heart failure because their right ventricle is doing the left ventricle's job. That's just one of many examples. Just as they can be admitted for a cardiac condition, they also can be admitted for non-cardiac things like appendicitis or a delivery, a hernia operation, something that would require general anesthesia or local anesthesia. And so these patients will interface with all different parts of the medical community, as we mentioned.
Certainly, the experience I've had and many of our colleagues, it can be quite intimidating, being presented with a patient, who has just been admitted to even just a general care ward, let alone an ICU. the history of very sort of scrambled anatomy, but we see increasingly so, and this probably relates to their improved survival, that they've had many procedures and surgical procedures, and just trying to even think about what the anatomy is can be really challenging. So when we are faced with a patient, let's just say in the general unit, they're not critically ill. At what point, Joe, do we need to consult with an adult congenital heart disease specialist? And I'm talking about the non-cardiac presentations, perhaps, because it may be that you don't even anticipate there's going to be a problem because you're not used to looking after these patients. So maybe some tips in terms of when should you seek additional help with the management of these patients when they're hospitalized outside of an ICU.
I think generally speaking, there should be a low threshold. These patients on the surface may appear well, but sometimes their complexity can be deceiving, particularly when we're talking about an anesthesia procedure. Putting them to sleep can be challenging and treacherous sometimes. So I would generally have a low threshold, particularly if there's an eponym involved. If there's
Such as?
Fallot, Fontaine, Mustard, and many others. If there's an eponym involved, or they've had a surgery named after somebody, or a condition named after somebody, I would have a very low threshold. So I would, and just from being on the receiving end of many consults, I would much rather be invited early to take care of this patient than be invited after there's a problem. So we're always happy to help for these patients. If someone has a very simple even a simple cardiac condition can be deceiving. For example, tetralogy or coarctation of the aorta. Coarctation of the aorta seemingly is a very simple condition, but there are many treacherous problems. Depending on the surgery, they may have an absent or diminished blood pressure on the left arm, for example, where if you tried to measure the blood pressure in that arm, you would think that the blood pressure was very low. These patients can be increased risk of aortopathy, ascending aneurysms, dissections. These patients may be increased risk of having brain bleeds, baryaneurysms, and then just to know where to put an IV, where to check a blood pressure, where to put a central line if you needed to. Sometimes it can be involved, and getting expert help is important.
I was just thinking as you're just going through those very practical issues there, that for anyone of our listeners, who's not a cardiologist, they maybe already feel quite challenged in looking after these patients. Certainly, in my experience, some of the threshold for consulting someone actually comes because the patient or a family member, they've been looked after by someone like you, maybe for 10 or 15 years, and they'll say, please let Dr. Jokhadar know that, I'm in hospital here. And so just notifying their regular adult congenital heart disease specialist that patient is in hospital, could be one very easy step, and that's an easy one to follow. What about in the intensive care? So as I introduced you at the beginning, you are an intensive care specialist. I've worked in that environment for a long time. And again, these are some of the most challenging patients, because they have a very complex, if not unique, hemodynamic profile. Their physiology takes a while to sort of really understand. And as I said earlier, even their anatomy, what's connected to what, can be really challenging. So tell me about how you approach these patients in the intensive care. And many of them, again, may be coming in with cardiac problems. You talked about arrhythmias, heart failure, maybe endocarditis, but they could also be there because of a non-cardiac illness that's put them in intensive care. So maybe just walk us through in terms of how you approach those patients. Obviously, we can't focus on any specific problem there, But as I said, we're lucky. We've got people like you working in an area of critical care, but not everyone does, and we'll come back to that in a moment.
I think generally involving a congenital specialist early. If one is not available, I would have a very low threshold to transfer. Um, and then just looking at the vitals. For example, their oxygen. What is their baseline oxygen saturation? It may not be 100%. They may be a cyanotic, and giving them more oxygen may potentially be harmful. Where to put an IV or a central line or an arterial line to get an accurate measurement. Um, the risk of thromboembolic events from bubbles crossing from the blue side to the red side if someone does not have the appropriate filters in place for a cyanotic patient. And then how to manage a ventilator in some of these patients can be quite challenging. For example, patients with single ventricle physiology or a Fontan, pulmonary hypertension. You have to be very careful about positive pressure ventilation, rapid extubation when possible. Um, and again, just knowing how things are hooked up. Sometimes that takes a lot of digging into the chart and detective work, looking for evidence of a sternotomy or a thoracotomy, checking if the pulses are equal and synchronous, checking a blood pressure cuff in the leg. So it's as you pointed out, it can be quite involved.
Well, maybe in a subsequent podcast, we'll address some of those issues with really as we think about specific situations and history. You talked about coarctation, tetralogy of Fallot. But you talked about having a low threshold for transferring patients, and that sort of brings me to, I think, an important question and that is, what proportion of major medical centers in this country actually have access to adult congenital heart disease specialists?
Thankfully, the number is growing. Thankfully, and one can access that pretty easily by going to a website that has a directory in it, ACHA Heart heart.org, ACHAheart.org. There's a direct link to a directory, and if they're at or near a congenital specialist, it has all the contact information and all the local expertise. And thankfully, within the last 10 to 20 years, there's been a dramatic increase in access to congenital heart disease expertise.
But I suspect there are still a paucity of people like yourself, who are trained in critical care medicine, working in that environment, and trained in adult congenital heart disease. Is that correct?
I think so, yeah.
Okay. And then in general then, I mean, what is the outcome of these patients? I mean, do we have a lot of data just in general in terms of an adult congenital heart disease patient who gets admitted to the ICU? What is the outcome?
Well, we actually published a paper just last year on this topic of our Mayo Clinic experience, and the outcomes are highly variable depending on the underlying condition. And one of the good things is many of our patients are young, which is protective. But there are no large scale data that I'm aware of about the outcomes for these patients when they're hospitalized.
So it seems that there may still be some gaps in research in this patient population. And I then would just maybe finish up by asking you, in cardiology, we know that we have so many guidelines, for so many conditions. And we've lost count of the number of class 1, 2 recommendations. I mean, they're in probably the hundreds of thousands, perhaps now. Do we have good guidelines to help us manage adult congenital heart disease patients when they're hospitalized?
We have guidelines from the American College of Cardiology, American Heart Association, that are excellent, but can't be comprehensive. And we also have excellent guidelines from the European Heart Society that are also excellent, but just cannot be comprehensive. Every patient is different. There's a lot of nuance and expertise, and also, it's team sport. none of us are smart enough to be able to take care of these patients on our own. So we need the help of the interventional cardiologists, electrophysiologists, pediatric cardiologists, surgeons, and then depending on what condition they have, and then our nurses have to have certain familiarity and experience. So this is respiratory therapists, team sport, and the better the cohesion between the various team members, I feel the outcomes are better in my experience.
Okay, well, that's a very nice way to end our discussion, today. Just emphasizing the importance of teamwork is so important, and probably even, for this group of patients, maybe even more important because of the complexity there.
Yes, sir.
So, Maan, I really want to thank you for your time. As I said, we will be seeing you again and listening to you again as we go to the next in the series of managing the patients with adult congenital heart disease.
Thank you, Dr. Bell.
And I want to thank our listeners for joining us. I hope you will join us for future podcasts, but particularly as a follow-up to today's.
At Mayo Clinic, relentless learning fuels world-class care. I'm Dr. Rajiv Gulati, Chair of the Division of Interventional Cardiology. If today's episode gave you a fresh insight, imagine what a full course can do for your patients. Head to cveducation.mayo.edu and explore our live and online programs, our quick on-demand modules, and our CME accredited masterclasses created and taught by the very voices you trust here. Join thousands of clinicians who've already turned curiosity into expertise. Level up your practice now at cveducation.mayo.edu.